We're now going to hear from Leslie Arnott, who is the Consumer Partnerships Lead and the Chair of the Consumer and Community Involvement Committee of our National Women's Health Research, Translation and Impact Committee. That's a mouthful. Look at all those letters I could do.
Affectionately known as?
Affectionately known as Wharton, and unaffectionately known as Wharton by some people, but I won't have it. I'm not going to have Wharton. And then I also would ask you to welcome Sarah Lukeman, who is the Chair of our Centre's very own Consumer and Community Involvement Committee. They're going to talk to you a bit about CCI, and then we're going to go to our panel where you can ask them anything you like about engaging and involving consumers in research. Thank you. Thank you, guys.
Away we go, Sarah, come on. Okay, you can clap. It's okay. Thank you so much for joining us, and I hope that you don't fall asleep after you've had your food, because that's indeed what actually happens a lot of the time. I'm going to introduce our panel a little bit later when we go to have a chat with them and ask them questions. But Sarah and I are going to co-present together today. I too would also like to acknowledge the land on which we live, work and play here today, and acknowledge the elders past, present and emerging of this land, and acknowledge that sovereignty was never ceded, and we need to work hard to make sure that that actually happens. So the presentation will go like this. Sarah and I will present first, and then I'll introduce you to the panel members, Nafi, Cathy, Sarah, and Brigitte. And after that, we'll actually put questions to the audience as well, and also you're most welcome to ask questions.
So, hello everybody, lovely to be here. As was said by Deb in the introduction, I'm the Chair of the Consumer and Community Involvement Committee for the Centre for Women's Health Research. And this is our very small committee at this point in time. Brigitte and Nafi are on our panel today, and Kate is in our audience. We are a brand new committee for a brand new program, and we're really excited to actually be here at the start. We're also all very pleased to actually be part of the strategic planning session that's going to be on this afternoon, that consumer and community involvement is really embedded in the Centre for Women's Health Research right from the start. We're very small, but we are developing a term of reference, and we're hoping to get to 6 to 8 committee members. So if you know anybody who might be interested in joining the committee, please pass on their names. We'd be very happy to have them join us. So yes, we're all very pleased to be in partnership with all the researchers and clinicians at the Centre for Women's Health Research.
So we thought we'd kick off this session with talking about involvement, engagement, and participation, and what the differences are. So involvement, consumer involvement, is doing research with or by members of the public, rather than doing research to, about, or for them. And this information comes directly off the Monash Partners website. So if you ever want to go there, they've got some terrific resources for consumers and also for researchers working with consumers. It's where you're working in a partnership with patients, the public, or members of your local communities, consumers, in your research projects. So those consumers are they're integral parts and integral members of your research team. So examples for that might be having consumers sitting on your steering committee, on your management group, helping them design your research projects, so co-designing with them, helping to analyse your findings, and then they can help share your findings as well. Deb, that smacks of something that we were talking about before, of using the consumer voice to actually propel the research evidence. So it's quite useful in that regard. So participation is probably something that most of you are familiar with if you're in research, and that's where you have patients, public, or members of the community as research participants. So you're actually collecting data from them, and for participation, of course, you absolutely have to have research ethical approval. And engagement, this is the kind of the umbrella term that we always use, consumer engagement. It's different. Engagement is different to involvement, and it's really important to understand the two. So engagement is where you share your findings or your research projects with the community. So you can absolutely involve members of the public to share your research, but it's a one-way activity. You're projecting your research onto an audience and not necessarily expecting anything back from them in return.
So a little bit more then about the involvement, what it is and what it isn't. There's a lot of terms floating out there. I've put up a couple: the co-creation, co-design, co-production. There's consumer-led research. There's the patient experience. The terms are actually can be very confusing. They're often substituted for each other. The key thing to remember in all of this is that what you're looking for is a sharing of power between the researchers and clinicians who traditionally have the power and the community, the people that you're actually doing the research for and on behalf of. So what ideally we're having is doing research with consumers. What is not consumer involvement is just having a name on a research application. It's not a one-off thing, it's an ongoing relationship. And like any relationship, you need to put something into that relationship to get something back. It takes time, it takes resources, not necessarily a lot of resources, but it's very important in a lot of funding applications these days to demonstrate that you have consumer involvement. And a very good way to demonstrate that is actually have a line item for budget. What you should all be trying to do is ensure that your consumer is not out of pocket to participate in your meetings or in your research, and ideally is actually remunerated for their experience. They are an expert in the lived experience, and like the other experts in your team, they should be compensated for the sharing of that expertise. Just down the bottom there, and I will point out these slides are going to be shared with you. We've got, they're all hot linked, so you can follow through to the sources. The International Association of Public Participation, IAP2, they have a spectrum of public participation. And it's not that there's a right or wrong place for you to be on that spectrum, but you do need to think about how far to the right you can go. So informing and consulting is quite passive, one-directional. Ideally, we're aiming for involving and hopefully over time moving up to collaborating and actually empowering consumers to contribute to your research.
So the big question is, who is a health consumer? Are we on to 5? Yep. Yeah. So, as stated earlier, consumer involvement is about working with consumers and or the community in partnership, doing projects with consumers rather than about or for them. But there is a catch, and Sarah just alluded to that. Oh, you've switched the slide, did you?
No, that's where we are.
Oh, my apologies. Okay, scrap that. We're all consumers of the healthcare system. Yeah? So lots of people will say, well, that means that anybody can be a consumer on a working group or a steering committee and that type of thing. It's a little dangerous when you start doing that. So what we're trying to do is absolutely we are consumers of the healthcare system, but we want to differentiate that when we become a consumer advisor or a consumer representative, that we are indeed independent of the others sitting on that committee because it brings a different perspective, right? There's a distinction, and keeping the consumer voice independent at the table is really important. So committees already have researchers and or clinicians. If you have somebody who is a retired clinician and or researcher coming to the table, it means that they're actually joining in that group of researchers and clinicians that are already there. If you've already got 12 sitting around there, you don't need another one as well. And the other thing too is that consumers, pure consumers, actually come from a completely different perspective. It's either just the lived experience or it's the experience of the system, and it's the knowledge of the system that they have gained from a completely different standpoint. So you want to take advantage of that and you want to embrace that information rather than actually approaching it from a research or a clinical perspective. The other thing too is that it's really, really advantageous to try and find consumers who actually represent groups. So there's consumer-led organisations and there's also women's health peak bodies that also are connected into consumer networks. And the reason why that's fantastic is because they bring more voices to the table rather than offering their own personal experience. The other thing too is that information that is gleaned in that committee or that working group can be taken back to the organised group, and they can provide comment and consensus to then bring that back to the committee. So there's a really nice reciprocity of information exchange with a broader group of voices rather than just from that one person. The other question to ask yourself is, how many consumers should we have? How many consumers should we work with? Well, I guess it depends on the size of the group. You know, if you've got around 10 people, maybe one consumer might be enough. If you've got 12 to 15, one consumer is enormously vulnerable. They're also enormously vulnerable if all they bring is the lived experience to the space and not a systems knowledge to the space. So the other thing that you can do is actually, when you're choosing your consumers, is to maybe mix the lived experience with the systems knowledge. If your group is even bigger than that, 3 is absolutely ideal. So 1 is vulnerable, 2 is supportive, 3 is empowering, and it brings lots more voices to the table, and that's what you want. You want to increase the voices to the table as much as you possibly can. I was just going to make one other point too. Just talking about the Wharton committees, my job is actually to find consumer representatives for all of our committees. And we have 9 health priorities, 9 women's health priorities that we go by. So not only am I looking for, because Wharton it's a fairly high-powered machine, so to speak. We're sitting around with clinicians and or researchers who are at the top of their game from across this country. So I can't pluck somebody off the street with a lived experience and actually ask them to hold their own. It's not fair on them, it's not fair on the other people on the committee, and it's completely ineffectual. So what I'm looking for at that level, that's the other thing too, you need to look for consumers at different levels as clinicians and researchers are at different levels of their career. So are consumers, they're at the different levels of their experiences. Some have sat on communities for years. Some have just started off. I'm a dinosaur. I've been in it for like 21 years and I'm not going away, sorry. But in Wharton, I'm looking for people who are at that level where they can hold their own. They not only have the lived experience, but they have a systems experience, not only the healthcare system, but the system in research and also policy and also advocacy, and they have good, strong, solid voices with knowledge behind them back. The other thing too is you take somebody like Sarah, for instance. Sarah is a consumer representative, a highly oiled machine in that regard. She was also a chemical engineer in the mining industry. That's quite useful. Believe it or not, there are skills in that are immediately transferable into the space, so keep that in mind too.
So, well, you can find yourself a health consumer. How can you help yourself work well with them? And there's heaps of resources and training out there. And this is just a selection of ones that I know, I've used, I recommend to researchers that I work with. And as I said, they're all hot linked. These will be made available to you. We have tried to focus on New South Wales and national here. But the one I really want to just highlight to you is the top resource there from ARA, the Involving Consumers in Health and Medical Research Handbook, or the CCI Handbook as we call it in shorthand. It's got over 30 resources. It addresses organisations like HMRI and the university, individual researchers, consumers, and clinicians in how to do consumer involvement well. And some of those resources include a listing of the types of involvement, what a consumer could actually do, how to recruit consumers, how to develop an expression of interest for what you want your consumer to do and advertise that, the costs involved with consumer involvement and how you could remunerate them, developing terms of reference and an involvement agreement with the consumer. I've got to say I actually don't have an involvement agreement with any of my researchers, but it's something that I'm going to start working on. And the last one I really wanted to share with you was evaluation of your consumer involvement process. And that's something that both the researcher and consumer can do together. I know as a consumer, I get a lot out of being involved with researchers, and I know they get a lot out of it as well, but it's really useful to share what you've both gotten out of the process and then improve on that for the next time. How do you find a consumer is a question we get all the time, and Leslie did allude to this earlier. Again, we've put there a whole lot of different resources that are available to you. The Consumers Health Forum nationally and Health Consumers New South Wales. If you do research in a specific area, so my background is cancer, so Cancer Voices New South Wales actually have an online process where you can request a consumer. They have hundreds of cancer consumers like me across Australia actually, and they will put a call out to their network and see if they can connect you with a consumer for your research. And the last one I just wanted to highlight on this slide, HMRI has just recently appointed Gillian Mason as the Consumer and Community Involvement Lead. So I've got a hot link there if you want to email her, and she would love to hear from you. She unfortunately doesn't work here today. If you need something in terms of consumer involvement, let HMRI know, because they're still figuring out how they can support the various 19 programs here. So that would be a really good way to go. But we don't want to take up too much time us talking. I'll hand back to Leslie for our panel discussion.
Great. Thanks, Sarah. I'll first introduce our panel. I'll start with Sarah first, just because she's closest to me. As stated earlier, she was a chemical engineer in the mining industry until 2006, when she was diagnosed with a very rare form of leukemia. She's allowed me to share that with you all. And she was lucky to join a trial, the outcome of which has put her in complete molecular remission. So years later, Sarah did some consumer training with New South Wales in 2016, and she's worked with a number of science researchers ever since. And for 2 years, she was the community engagement coordinator with the HCRA, helping to connect consumers and researchers and providing training and support. So as said earlier, she's a seasoned consumer representative and advisor, and has sat on numerous organisational committees such as Cancer Voices New South Wales Regional Health Partners, and the HMRI Precision Medicine Program. This is just to name a few. There's lots more. And I'm pleased that recently she joined us at the Women's Health, actually at Wharton. I was going to say the whole thing, but you now know it's called Wharton, where she sits on the Workforce Development Subcommittee. So please welcome Sarah. Cathy Leane. Leane. I'm going to say it right, Leane. Cathy's a Darug woman, originally from Western Sydney, but now lives in Adelaide. Her position is the Manager of Strategic Partnerships at the Women's and Children's Health Network in Adelaide. Part of her role is to support partnerships with researchers, and she also supports the Consumer and Community Program by providing voice for Indigenous women for whom the services care. She brings to the table various voices from her Indigenous networks through her work. She's a chair of the Aboriginal Advisory Group at Adelaide University, chair of the Aboriginal Advisory Group, which advises on Aboriginal family studies, and this focuses on the experience of women in birth. Please welcome Cathy. Brigitte. Brigitte first encountered health research in Germany about 25 years ago when she was involved in a study that was looking at mothers with preeclampsia, and they were doing some genetic testing to see if their daughters were prone to developing preeclampsia as well. She has sat on and co-chaired a number of committees as consumer representative for organisations such as the Central Coast Local Health District, the Elevating the Human Experience Committee for the Ministry of Health, has worked with the Clinical Excellence Commission and the New South Wales Regional Health Partners. Brigitte also brings to the space additional lived experience as she was diagnosed in 2017 with MS, and she has been involved in a longitudinal study on MS for the past 4 years. Will you welcome Brigitte, please? And that brings us to Nafi. Nafi is a researcher and an author. She's published several papers. She has a membership of professional bodies such as the International Sociological Association. She's at the Centre for Study of Violence, University of Castlemaine, and Hunter New England Human Research Ethics Committee. She's also, and this is a really good job to bring to the table, she is a multicultural health liaison officer in H&E Health. She's got extensive experience working with culturally and linguistically diverse communities and delivers regular lectures and training to health professionals on cultural aspects of health and cultural competency. Her research is in and around, and so is her book, around violence with culturally and linguistically diverse communities. Will you welcome Nafi, please? Thank you. So I'm first going to open up the questions to our panel, and then I'll open it up to the audience for you to ask some questions as well. So, Sarah, I'll start with you. You're closer to me. How have you been involved in health research? Just a snapshot.
So over the years, I've done a lot of things. I've sat on funding panels. Cancer Council New South Wales has a consumer panel that has equal weighting to their scientific panel for the allocation of their funding research, which is a fantastic model. I work with individual researchers. I'm listed as an associate investigator on their grant applications, which I review, put my input into. I meet with them regularly, not often, like quarterly, not so much in person over the last couple of years, but go and see the lab if I can. Advocacy, lots of different ways.
Okay.
Most have been mentioned. So.
And Brigitte, you come from Germany originally. You got involved in a study. How did you do that? How did you get involved with that, in that study on preeclampsia?
I was in hospital, obviously, with the preeclampsia, and I think my file got sent off to somebody, and they contacted me and asked me if I want to be a part of it and swap myself and my kids, and then they took me on, and a few months later I got the feedback on the research.
And that's a beautiful example of the lived experience in a research piece, absolutely. Cathy, what's the most important thing you want researchers to do?
Good morning, everybody. There's lots of things. And before I say anything, I'd like to just acknowledge the country we're on and traditional owners. I've really loved looking out the window here. I'm from Sydney, and this really reminds me of home, so I'm feeling a little bit homesick. I'm not sure if I want to go back to Adelaide tonight. But, researchers, Aboriginal people have a troubled history with researchers. We have a troubled history with health services. We've been done unto and over-researched in probably some of the most horrific ways. So most important aspects of research for us are about that building of trust, that feeling that we are leading and that understanding what the research is going to be about, and having control, having a say over how that research is undertaken, how that research is interpreted, and how that research is reported, and following on from that we have buy-in to how outcomes from that research are progressed. So it's trust and a sense of control. Or at least being, when you're partners, you have that control, so, yeah.
Great. Nafi, with your hat on...
Which one?
With your hat I'm just going to look up your role, your Health Liaison Officer.
Yeah.
I want you to put that hat on.
Sure.
What do you see as the barriers for researchers engaging with consumers?
Yeah. I think similar to what Kate said, CALD communities, cultural and linguistic diverse community, are underrepresented in research, health research, both as participant and both as a consumer, and also in clinical trials. So it's really important for researchers not to exclude them. And I'm sitting in Hunter New England Human Research Ethics Committees, and I saw many applications that when they just want to do any research, one of the exclusion criteria is people who don't speak English. And the reason they say that, they said, because it's a cost involved to use interpreters. So it's a new initiative with our unit, Multicultural Health Service. So we provide interpreters for all research across Hunter New England Health for free. And it can include translation of some like PIS and consent form. And also we can make a video, like a video for PIS for the population that don't speak English. So I think the first important thing is just the awareness for researchers that this definitely they can use free interpreter service. And the other thing is just probably the lack of awareness about why it's important to include CALD communities. Of course, it's 50% of population, according to recent census, born overseas or have family one parents or both born overseas, and the needs and challenges are complex. It's different. As I mentioned, one of the first things is language, but there are other challenges like navigating the health system, how to unfamiliarity with the health system, or the various needs, like specifically for refugees and newly humanitarian arrivals. So when they come to the country, so the past experience of trauma and complex trauma is very important to be considered when we're doing research with this community. And we recently developed a fact sheet about how to work with CALD community as a participant or as a community, and I'm happy to just share it probably for all the researchers in HMRI. That would be great.
That's great.
We also provide advice. If anybody needs some advice and feedback, we are happy to do that.
Yeah. So Nafi, let me just tease something out there. So your message is actually, where there's a will, there's a way.
Yeah.
It is possible to actually involve CALD communities in your research, even though they don't speak English.
Yeah.
And indeed, some of our research is actually about those very communities and those people who slip through the cracks because we're not actually researching them because they don't speak English. So we've got interpreters, and so what we need to do as researchers is actually redirect our funds so that we make sure that that is taken care of. Yeah. I just wanted to reflect on a project that I was asked to be part of as a consumer representative, and they were looking at third and fourth degree perinatal tears in various different populations, and the hospitals where they were going to recruit these women, I noted that there was about 40% where English was not their first language and or they were non-English speaking. And so I said, where are you going to be providing interpreters and support for these women? They said, well, we're not going to actually be putting those women in, recruiting those women. So I said, But your hospitals are about 40% of those women. And why wouldn't we be recruiting them? Because that's actually a population who are at higher risk of experiencing a 3rd and 4th degree tear, right? And they said, well, Leslie, we'll do that later. I've heard that so many times. This is the reason why, even though I've been in this for 21 years, I'm not going away, because I hear that all the time, which is they say, we're going to do that for the next one, and then the next one comes along and it doesn't happen. So I said to them, okay, so what you're saying to me is that you haven't allocated funds to actually attract non-English speaking or women with second language, English as their second language. And they said, well, yeah. And I said, so do you know what that's called? So can you please minute for me in the minutes of the steering committee that the consumer representative acknowledges that institutional racism is taking place during this discussion?
That's great.
So we have the power as I'm saying we, I'm not even a researcher. You have the power as researchers to stop doing that. So if you stop doing it, then we translate the stuff onto the floor and the clinicians will stop doing it, okay? So that's a really big message that Nafi just told you, gave you all the ways to do it. It can happen, okay? So let's do it. Yeah? I'm gonna open up the floor now for you to ask questions to our panel. And Casey's got a microphone, so please put your hand up if you have a question.
I think I can project. I'm right over in the corner. My question was about that last point. What do you do in research on which there isn't a grant? So, for example, I'm in clinical psychology and we have a quick turnover with students in their masters. So if you don't have a grant, so where do you get the money for the interpreters?
It's free.
From who?
From Multicultural Health Service, Healthcare Interpreter Service.
Oh, okay.
Yeah, just go to the Hunter New England Health website, click Multicultural Health Interpreter Service, contact the manager, and it's done.
Wow. Thank you.
This is a relatively new thing, though.
That's new, yes.
So it's not that you didn't know about it, that it's been there for years. It is quite new, but we're really excited to share that with you.
Thank you.
Tick. Any other questions? While you're thinking of one, there was one other point that I wanted to make, is that if we're going to involve consumers, because we have a standard too now that says that we need to involve consumers at all levels of service delivery in terms of research, that as clinicians and researchers, when you start your projects, you've traditionally given this amount of time to your projects. And now Standard 2 says, sorry, you've got a partner now with consumers. So that means you're taking some consumers and putting them into that project piece, and you've got to gain a relationship from them and learn their lived experience and gain their trust within that time period. And as my dad would say, it's never going to fly, Orville. And it doesn't. And this is what gets us every single time, is that we don't expand the timeframes of the projects to allow for really, really good consumer involvement in projects. So I'll say that when you say we're going to hold a 2-hour workshop for consumers to find out all the information we need for a research project, it doesn't work. You need about a day or two to actually, number one, get a good feel from the group and get them to trust each other and you to get that information. And number two, to actually explore that narrative so that you get those salient points and you can really hear what those consumers want you to research about. Yeah. Deb.
Thanks, Leslie. I might add to that in addition to the time it takes to talk with consumers in the first place, you then need to add time after that in order to incorporate what has been said into the research. And that can take ages. And then you really should check back once you've done that in order to make sure that you've heard the voice correctly and that you've done it in a sort of valid way. Yeah. And it's not what we're used to doing, and it is not in any models around that we would typically use. So I think it does require some thinking at the very, very beginning.
Middle, and end.
Kind of trying to do. Yeah. I wanted to ask you perhaps might be a little bit more personal question. But one of the things when I first started talking with consumers that bothered me was, am I going to upset this person if I talk about the things that are challenging for them about dealing with the health system or dealing with researchers, whether that's because of illness or because of English as a second language or having an Aboriginal history where researchers have been appalling in the past. And so my concern was and remains that, am I going to upset someone? Am I going to say the wrong thing? Am I going to be walking along here with my foot in my mouth? I don't want to make things worse for anybody.
Sarah, do you want to talk to that?
Yeah, I'll start. So I'm obviously not from a culturally and linguistically diverse background. You actually have ancestors who came out on the first fleet, not of their own volition. And thankfully don't have a domestic violence background. However, I've lived with cancer, and I often have had researchers say, "Oh, I'm really worried about upsetting somebody." They may not, talking about their cancer experience. And so I usually share a few things. The first is that somebody who has put their hand up to be involved with research has actually worked through to a point where they think they can add value. So it's not just anybody off the street. They've actually chosen to be involved. My experience now, which is quite extensive with all the various cancer consumers that I've met, is that they've usually worked through they're usually out of active treatment or are being chronically managed. And there's a lot with immunotherapy, for example, who are going to be on treatment forever but are stable. So they have the time and the physical energy to put into the research. They're not easily upset as a result. They've shared their story. They've lived through it. However, if they do get upset, it doesn't matter.
And what's cancer?
Cancer's shit anyway, so yeah, But if you as a researcher are uncomfortable with that, you need to get comfortable with it. And I would imagine it would be the same with domestic violence. If you're researching in an area that is shit, you've got to be comfortable with those shit conversations. And there's a lot of support out there. So I've done accidental counselling. It's funny how you sort of attract people. I've had people in Maya in the toilets you just end up sort of sharing, your cancer experience with somebody. And it's just that. Those relationships, those genuine conversations, and just acknowledging that, yes, it's shit, and moving on. And you need to get comfortable with that. Your consumer is probably pretty comfortable with it already because they've lived through it.
That's great. Well done.
Can I add something about CALD community as well? And I think for most of CALD community is the same. They are usually happy to share their experience in any area in health about racism or whatever. But I always, in my cultural competency training, said the best way to know what's right, just ask them in a nice way. Are you okay or happy? And if they said no, that's it.
That's great.
There's no, any hard way. Just ask.
It's just a simple question. That's fantastic. Sarah made a really good point about feeling comfortable with the uncomfortable. Consumers bring different perspectives to the table. They're different to yours. There is going to be argy-bargy. If you're going to partner with them, you've got to even up the power imbalance. And it's okay to feel really uncomfortable and get edgy. They'll actually applaud you for it. It's okay. Just go to the uncomfortable, and you know that you're going to be in a safe space. I'll come to you just 1 second. Kate, you've got a question there?
Yeah, well, firstly, a comment and a question. I'm just reflecting on how incredibly privileged we are to have this opportunity with you, so thank you all very, very much. My question pertains to where I come from. Is a large patch of our world is rural and remote. And so the opportunities to obtain feedback from consumers who are related to organisation or to sort of support groups or whatever are quite scant. And therefore, I'm interested to learn from you what you think if we were to train, because I think they need training and support to participate in a meaningful way and to look after themselves too. What are the elements of the training modules that you think are important? Or what skills do you think it's the person, skills and knowledge that the person or people should have?
Can I just answer it really quickly, then I'll go to the panel. That's a really good question, Kate. Again, it depends on what the panel's doing, or what that committee or group is. So what do you want out of the consumer? If it's a consumer advisory committee made up of all consumers, then it's really good to have the lived experience in there, and it's fantastic. If it's a committee that has a bunch of researchers and clinicians on it, you probably need somebody who's got some committee experience and knows the drill and may have also knowledge of the healthcare system. So there's different skills for different committees, given the experience of the consumer. There are modules, though, out there, like one of them that Sarah did mention lots, but your Monash Partners one is fantastic because they've also got modules on training consumers, but also training researchers to work with consumers, which is brilliant. It's absolutely fantastic. Did somebody from the panel want to answer that? Anything else about that
just
point?
From an Aboriginal perspective, I agree with what Leslie said. It's what do you want the consumer to engage with? How do you want them? Where are they going to be sitting? For Aboriginal people, it's not always comfortable to be the one person sitting on a high-level committee. Yeah. And if you want somebody like that, I think, yes, look for someone who's already has a skill set developed, but acknowledge too that there may be people in community that have to speak for them first, that there are protocols when engaging with Aboriginal people. So the person who's employed and you think has capacity to speak at that level, or with a little bit of support may be able to advocate at that level, may not be able to speak there because their aunt or their grandmother is the one who has to be consulted. So what we have found works best is to actually take what you're doing to where the community is, and then sit and talk and work with community, and in doing that the voices will come to the fore, and it's about we talk about having yarn, so it's about not just hearing from community about what they want, but it's about telling your story as well. It's good to share a little bit about your personal story, but where do you work, what are you doing, what are you hoping to achieve? So in some ways that's part of the education, aside from the formal opportunities that Leslie has just alluded to. And then we do a lot of work in the healthcare setting around supporting people really to understand confidentiality, to understand structures and processes, what it looks like strategically rather than operationally. Some of those, but that takes time, and it's about sitting with a group and having those discussions rather than bringing people into a formal education training. And it might be repeated conversations over time for things to make sense. Yeah.
Sarah?
I just want to add a couple of things here. Firstly, every consumer is going to be different. So they're coming in with different knowledge. So it may well be quite a unique thing for each person. Cancer Council New South Wales has been providing consumer and research training since 2005. And a large part of that is actually explaining the research process to people who aren't involved with it. And it still amazes me how you researchers actually live on that funding by funding that process, putting in application after application, 12%, 8% getting funded. It's just, coming from corporate Australia, it just is mind-boggling. So learn, if you're a researcher, making sure that the consumer understands how research works, just that that logistics of it. And there are courses out there for it. So yeah, everybody sort of will have different needs. But the really important thing always, and we haven't mentioned this, I realised, is don't use jargon. Lay language. Check the understanding with your consumer, because if you're just sitting there talking, there's a problem.
Yeah, they often miss the part after listen carefully.
Yeah. So I like the story of the person who was sitting in a meeting and they kept talking about the nun, and she wondered who this nun was and what the nun had to do with it. So nurse unit manager for you clinicians is, but for those of us who aren't in the health system, we don't know what that is.
Yeah, by the way, what is ANROSE?
Australian National Research Organisation.
Oh, thank you so much.
Sorry to cut you off, Sarah. Well, one thing what was very valuable for myself, and I think for a lot of researchers, was one workshop we did from the New South Wales Regional Health Partners, held by the Health Consumers New South Wales, bringing together researchers and consumers in one room, doing a workshop for all of them, for both sides. But the most valuable thing on that day was the morning tea breaks, the lunch breaks, the afternoon breaks, where we sat together on those tables and took all our hats off and came together. And essentially, at the end of the day, we always said, researchers and consumers, we're all here for the same reason. We want to elevate the outcome for our community, and I think that's the main thing. We are here because we all want the same. We just have to add all the pieces to the puzzle.
Gorgeous. Thank you so much, Brigitte. We meet in different ways, and food is magic. There was a question at the back here.
I think my question was already partially answered. I have a very similar question here. I'm actually right now, I work as part of research organization. We are creating a consumer advisory group. It's a 12 months pilot. And while from other research organizations, we received some guidance that we should be engaging or providing training for consumers. We should be engaging with consumers who are already trained in how to engage with research. We are also wanting to engage consumers from harder to reach rural and remote areas. And I wonder, could we speak a little bit to that, whether it's always a good idea to engage with consumers who are already trained in our attempt to also to reach to much harder to reach populations who may not have access to trainings.
Can I just talk to that just for a second? That's a really good question. That's where the mix is really powerful. So the lived experience is enormously powerful. And then you get experienced consumers who actually know the drill of being on a committee and know the questions to ask and all that type of thing, and also have a knowledge of the healthcare system from a systems point of view, so to speak. So I would seek out, if you're going to put a consumer advisory group together, get the mix. It's really, really good, and they support each other fantastically. Cathy made a point before where one Indigenous person on a committee, get 2 or 3. Why do you have to stop at 1? It provides support and empowerment. Anybody else?
In terms of regional and rural representation, particularly as a women's health research organisation, the Country Women's Association, ladies and men. So I'm a CWA member. When I got sick, I was living 900 kilometres north of Perth, and I had to relocate to Perth for my treatment. So I understand living regionally. I live in Maitland now, and I was in Singleton for 10 years before that. So CWA they're great. They provide hospital support to a lot of regional hospitals, so they're already connected into local communities. There's a state office or head office in New South Wales, in Mascot, CWA. That's one great place. The local council. So I spent a term on Singleton Council as an elected representative. They have their fingers in everything, local government, particularly in small towns. There's so many groups, your Rotaries, your Lions clubs. Small regional towns are actually run by the volunteer groups, and they're a really easy way to get in touch with a lot of connected people. So just think outside the box. It's actually not that hard. And then every hospital has a community group, not a board as such. I've forgotten what the name is.
You're talking about the CAC, a Community Advisory Committee?
Yep, the CAC, Community Advisory Committee. Terrible name, isn't it? CAC. And they tend to be a group of very community-minded people. Reach out to them. It's often hard to actually get a contact, but if you're in the health system, you're probably going to find that easier than I would as somebody outside the health system. So I hope that's a few tangible avenues that you could go down, and you could probably find at least an email or phone contact with a quick search on the internet.
Sorry, can I add, if you want any consumer for call background, we got a multicultural advisory committee in all hospitals across Hunter New England Health, so they can help as well, and also some settlement services or community organization. They got some people that are interested.
Yeah, that's great. Was there another question? Yep. Okay.
Not really a question, because I'm also on the CCI committee. More of a comment that might also help. Just being clear about roles and responsibilities for consumer representatives on your committees is going to be really helpful. And I know we've kind of touched on that with some other comments that have been made, but just being really clear about what you expect that consumer to give or to feed back into the committee to make them feel safe, and to help them really understand what the parameters of their role is.
That's a great point. Thanks, Kate. I'd actually like to ask the audience a question. Do I have any other questions from the audience? Nope. What do you think about the idea of consumers working with researchers, not in a research project, but once you've got your evidence from your research and you want to get it onto the floor to affect health outcomes, what do you think about the idea of not stopping partnering with consumers at the end of the research, but leveraging their voices to help lobby for your research evidence to your policymakers, to your health departments, to your hospitals, to get that evidence in to actually decrease the amount of time it takes for evidence to get on the floor, which is 17 years. It probably should be about 17 days. And what do you think about that? And how do you think you would go about that? Is that an idea that you would consider? I tell you why I'm asking. It's been prompted by the presentation we had from Padway and the minister presenting, that she started off, or didn't start off, but she mentioned stopping from the start. Well, where is the start? Is that primary schools? And I know that we have a respectful relationship program in primary schools. Is that enough? And does your research talk about sexual violence as in what is sexual violence? When do you start drawing the line between, oh, he's just being playful or whatever it is? Do they actually know what that is in the schools? And is it possible to get your research from, if it's not primary schools, it's in high schools, when children become sexually active and their hormones are going nuts by the time they're 14. That's where the consumer voices would be great to get in, link up your research to the education department and get some consumer voices to lobby into that, because you can't fire a consumer if you're too outspoken. And I know that sometimes you have to be careful. There's power differentials and all that type of thing. We don't have to worry about the power differential if we're speaking up and pushing that evidence forward.
So I thank you for bringing that up, Leslie. That was a brief conversation we had after the presentation this morning. I think that one of the clearest examples of this are Grace Tame and in the violence spectrum, and before her, Rosie Batty in the intimate partner violence space, where they were able to do things and say things that as violence researchers we cannot do. And so I do think this is something that has value and is definitely worth more conversations. So I will leave my comment there, but happy for anyone else to take the mic. I think it's a marvellous idea.
Is there anybody else who would like to make comment to that? Or would like to perhaps toy with the idea?
I can say that in cancer consumer work, that is actually the plan. That is what we do. It's not just doing the research, it's actually having it becoming standard of care. We want those breakthroughs, because time is limited once you get a cancer diagnosis, and we want these things implemented ASAP.
Sarah, do you want to talk to the idea of lobbying about treatment in the home?
So I was, back in 2006, I was on a number of different trials, not just my chemotherapy trial, but I was also on an exercise trial to rebuild muscle mass. And when I was looking at having to go back into hospital for a 6-week period, it was quite a depressing idea, having gone into septic shock the previous time I'd been in hospital, and my daughters were 4 and 6 at the time. And my fantastic haematologist got me into chemotherapy in the home program. I wasn't actually at my home. I was in accommodation provided by the Leukemia Foundation in Perth, but it was a 3-bedroom unit that my parents were living in, because they were looking after my kids while my husband could still go to work and I was immunocompromised and having treatment. But the nurses came to me and gave me the treatment. They didn't have to come visit me in hospital. I was there in the morning when my eldest daughter went off to school. I was there in the afternoon when she came home.
And Sarah, how prevalent is that?
It's not available in Hunter New England Health. It's not widely available anywhere, but for me as a patient, it was it was just such a relief, and I spent less time in hospital. For our family, it was just such a great improvement. And if you're looking for patient-centred care, I couldn't speak more highly about it. And I'm quite sure that one of the reasons I got it was that my haematologist, he's 3 days younger than me, he had daughters the same age. He knew what I was going through, what I'd been through. And
are you still lobbying?
Oh, look, I raise it every opportunity I can get. There's lots of things I raise, IPTAS, but yeah, consumers are great advocates. We've seen, we've talked about a lot of people come into consumer advocacy work because of trauma or because of a bad experience. But conversely, although cancer's a terrible experience, terrible thing to have happened, I had some great experiences. I compare them to the outcomes that some of my friends have had who are no longer with us. So I'm advocating for them as well. So people can bring good experiences as well as bad with them. And I think there's so many silos around. We need to share good experience as well as bad
as well
ones.
as bad. Deb, you just touched on something before when we were talking about leveraging the consumer voice to help get your research out there. And you mentioned Grace Tame, and there was Rosie Batty, and there was the woman from Parliament House, her name escapes me. Brittany Higgins, thank you. And they're all white. Mm-hmm. So when we get our voices out there, if you want to use our voices, we need to use a variety of voices. I just would like you to consider that.
Can I say something?
Yes.
We had a discussion before about advocacy and speaking up. Working in hospital for 12 years, and I used to do ward visit every day. I saw about 30 patients from CALD background. I could see that advocacy and speaking up is an issue for CALD communities. One part of it is language, but the main part of it is culture. So if you go to a room, I just give an example. If you go to a room in John Hunter, there are 4 patients. One of them is Chinese, one of them is African, 2 are white. Just stay for half a day, and you can see how many times the white people boss, but the other people, they don't ask for help, they don't speak up, and it's so many barriers. One of them, as I said, is language, but mainly is culture, is respect for health professionals. So they really need advocacy to speak up. And I think even with consumers, they need to be, I'm looking for consumer because I work in maternity as well as part of a support for CALD mothers, pregnant mothers. I just want a consumer, and no one wants to come. And I just offer, look, if you come, I can come and sit with you. And if you don't want to talk, just write it to me, and I can talk about your experience. So they need support. And maybe one of the reasons we can see women from CALD background, is that, barriers. So definitely we need to just work. Yeah.
I think we'd just like to bottle you all up and take you all with us. Pursuant to your idea and your discussion with Deb about the ongoing role of consumers, I think it's common sense. It's common sense on a whole lot of bases, but particularly with the imperative of impact and translation. It's a no-brainer, isn't it?
Well, yeah, I consider it a no-brainer too, but it doesn't happen. Yeah, so the common knowledge isn't that common. I'm getting a wrap-up, aren't I? Is that right? No, we got a question. Sorry. Nikki. Sorry, Nikki.
Is that on?
Yep.
Yes, I couldn't agree with you all more. Research isn't finished until it's translated into everyday routine care, and the best way we can do that is together. Parliament, influence, the decision makers don't listen to a single voice. They like it. It's more efficient for them, and it's far more powerful when we all go together as one. Absolutely. And that's what we need to do as part of that research translation process.
Yeah.
And we can help you.
Yeah. Is there any other questions from the audience at all?
Can I just say, as the Consumer and Community Involvement Committee, would just wanted to say that we're still trying to figure out what our role is. So if there's anything that you would like from us, please send through your ideas, your requests, any particular workshops, training. We're looking at holding 3 or 4 events each year about consumer involvement, so please reach out at any time.
That's great. Well done. Would you thank our panel members today? Thank you so much.